The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always.
Welcome back to the Virtual Curbside. We're very fortunate to have Shawn Mendenhall back to answer some questions about the episodes that we've had this month. Thanks, Shawn.
Thanks so much for having me back, you guys.
And as fate would have it, you're squeezing us in. You're off to do a conference, not in Cincinnati. Let's see, it's in Israel. That's a big trip.
That's right. Yeah, it'll be my first time to the Middle East. And this trip has been canceled once already, but we're excited to go over and share some of our experience with what we do for about 3 days, and then I'll have some time to tour.
Okay, that's wonderful. Well, let's dive right in. Any disclosures that you'd like to talk about?
Yes, I'm a consultant for a company called Polynovo, which is unrelated to this podcast.
Well, let's dive right in. First question, when you're looking at doing procedures, how do you balance orthopedic readiness, bone maturity, with developmental readiness and family goals?
Wow, that really brings a lot of the factors together that we think about. The hard part is, since this is such a new area of surgical treatment of spasticity, we don't have a lot of hard data to follow. So what we do is we often, just like you mentioned, just talk to the parents, talk to the patients about where they're at, what their goals are of treatment, and then often work together with their primary care physicians as well on picking the optimum timing for this. Typically, the way we think about it is when you have really tight spastic muscles, that can slow skeletal growth down. And so my hope is that I always see these kids as early as possible to just start the conversation about what are these treatment options that we have now and how can we fit those into sort of the normal growth and development of the child. So again, while we don't have a perfect timing on when we do this, we typically will start doing a lot of these surgeries, sometime before major growth happens, just to help relax the muscles so then there's not as much inhibition on bone growth.
I mean, that's an interesting perspective that I guess I haven't thought much about before, and that's that sometimes we want to make sure that they have a certain amount of maturity, but what you're saying is that we want to make sure that we give them the possibility for more growth.
Yeah. So again, not an ideal set of criteria developed yet, but the earlier we can start seeing these children, the better. And most of the time they come to me when the families learned about these treatment options and we deal with what we have. Sometimes I can be a little bit older in the teen years, but ideally I see them 4, 5, 6 years of age, and then we kind of start planning at that point how to move forward as a team, right? And it's not just me. It's oftentimes primary care providers, it's their PM&R physicians, sometimes are neurologists, they're therapists, and then we all sort of come up with a joint plan. And I think that's really the way for ideal care.
Second question is really closely related to that. And in some ways, I think it's asking you to comment sort of generally the relationship between the generalist and the specialists here. So let me dive into that question. Speaking of family goals, what's the best way for a pediatric provider to become an effective advocate for the patient in deciding about procedures? I feel the families get good explanations for the risks and benefits, but they often rely on us to help steer them through the options. Hearing your episodes has been a big help, but do you as a surgeon have any general advice for how we can best advocate for our patients?
Yeah, Paul, you bring up a really good point. I think the most important thing that pediatricians can do is just educate themselves with the options of what's out there besides their own little treatment realm. And the more that pediatricians know, I mean, your podcast is a perfect example, right? You're getting all this very subspecialized knowledge into the repertoire of pediatricians. by interviewing all of us that are so subspecialized, sometimes pediatricians just don't know that these options even exist. And so I
Right.
think the most important thing is just getting that knowledge out to pediatricians so then they have an understanding of what the possibilities are. And then they can, knowing that, they can help guide patients through their journey a little bit better. And there's often, before a patient sees me, there's often other specialists, right? So they often will see physical medicine and rehabilitation first. And so we've done some work with trying to educate that group more about this. For example, we just had the national meeting for the PM&R docs here in Salt Lake City just this last month. And so I had the opportunity to go meet with the whole pediatric group of PM&R docs and share some of the work that I do with spasticity. And there was a huge interest on their behalf because they're often the next line after the pediatrician for managing difficult spasticity. So they do a lot of the Botox injections and phenol injections and medical management of these kids. And so for them to learn that there's a really a permanent form of Botox, basically with the selective neurectomy procedure. They were very excited about that. And so it's getting the knowledge out there. And then once pediatricians have that knowledge, then they can say, here are some options to think about, whether that's right away, if they've already gone through a lot of the other medical management, or if they're ready to just come in and learn about it. And obviously, we try to send our notes back to our referring providers. And so they can often see the dialogue that we recorded in our documentation about what the options were that we gave to the patient. And so just keeping up to date on those letters, and then they can appropriately counsel the patient with that knowledge.
Well, it's not at all uncommon for me that a patient will come out of a situation and will have had a recommendation to have something done. And I go back and scramble to try to educate myself. Not that I'm going to be making the decision for them or even necessarily with them, but that I'm able to hold their hand a little bit through the process.
One thing that's very helpful, at least, and has been in my practice, is just open communication too with the subspecialist. So I absolutely love to get on the phone and talk with referring providers and just let them know some of my thoughts and what I have to offer. And having that open dialogue, I think, can be super helpful for the pediatricians to help guide the family as well. But I think at the end of the day, the parents are going to hear these options. They're going to get some knowledge about these procedures, and then they often will ask for advice from other providers within their treatment team. And so I think as long as there's some basic knowledge of these newer procedures, I think that can help guide the patient quite a bit.
And the other nice thing for us is that it enables us to look at the issues that may be impacted by the procedures and by those decisions and help be supportive across the whole life of the child issue as opposed to the organ system issue.
Yeah, exactly.
Next question. For patients who travel distances to get the procedures done, what should we watch for in the time following surgery? Pain, wound issues, nutritional concerns, regression in function, etc.
Yeah, those are some more really good questions. Oftentimes after we do these procedures, say we are doing a combination of some tendon or muscular work as well as the selective neurectomies, we often will place a splint and a dressing and a wrap over the extremity, and we have them leave it really until they see us back in follow-up, which could be 2, 3, sometimes even 4 weeks. And so typically we don't even look at the incisions because the rate of infection is so low, but that would be obviously the biggest concern early on is something like an infection or, things of that nature. So if a patient has this done and they're some distance away from our surgical centers, then certainly if they're having things like fevers or irritability or, just out of the ordinary amounts of pain or things like that, then I think it would be totally reasonable to unwrap the extremity, take a look at the incisions, make sure there's no infections, and then the splints can easily often just be put back on with a fresh wrap. And so I think looking out for things like infection, it's very rare that these patients have a lot of pain after, especially say we're only doing the selective neurectomy procedure. There's no musculoskeletal procedure. We often just do a light, soft wrap after those, no splinting or anything, because that means they had a more minor spasticity to begin with. And so in those patients, it's much easier to unwrap and take a look. And then it's just skin incisions. If we didn't have to move tendons around, it's often much smaller incisions. And the chance of pain, even though we're operating right on these nerves, we're separating the sensory nerves very carefully from the motor nerves. And then we go in and we obviously take away some of the motor nerves. But I haven't had many patients who complain of much pain, even with that manipulation of the nerves in surgery. And it's likely, again, because we're focusing on motor nerves and not sensory as much.
It's fascinating for me that something that is so intricate and difficult that it is the recovery is nuts and bolts recovery. It's surgical recovery.
Yeah, it is. And it gets a little bit more complicated when we are doing tendon transfers or major muscle lengthening or muscle releases, because then we have to keep that limb in a certain position with the splint. And then there's quite a bit of therapy that typically will start somewhere at the 4 to 5 week range after surgery. And so those patients, will be getting into therapists. And if they're away from our center a ways, then we often communicate directly with the therapists in their community. And our therapists have this really great relationship with many of the surrounding states and the therapists that work in these areas. And so they're communicating with them and coming up with a joint care plan, which I think is really nice. And sometimes there are little bumps in the road where the pediatrician may have to do an additional referral to a local therapist if our office didn't do it at the time of surgery. Or so sometimes there's some, interaction in that way as well, where we need the local quarterback pediatrician to help us out a little.
I think there's a lot about medical education that makes us feel insecure about asking questions sometimes. But I think the thing that's absolutely vital in every area, your area and all others, is collaboration is what makes it work.
Yeah, and we're always so much better as a multidisciplinary team that way. There's a lot of things that I don't think about as a surgeon that a pediatrician will think about. And so the more that we can just get together and communicate, all of my business cards have my email address and I share those with my patients. And so if they have questions, they can contact me or they can have their pediatricians contact me directly. And sometimes I wish there was a little better way to have more direct communication between primary care providers and us subspecialists.
I think the first hurdle is knowing that it's a reasonable thing, and,
Right.
and then we find a way to do it. Well, last question on an unrelated note, tell us more about what you do when you go to places like Ukraine to share your expertise, both with patients and providers. Do you go back repeatedly to the same places? Do you continue to give long distance advice once you get home? And how do you decide where to go?
Yeah, that's a fun question. And this is something that I've always wanted to do in my career is some outreach like this. And I just started a little over a year ago. I finally was in a good position with my career and my practice and my research and, endeavors on a local level. And so I had the opportunity to join up with a group called Iskra Global that does these trips to Ukraine. And so I've been twice now. And it's just an incredible experience, right? To go to an area that's totally different than our practice of medicine. But obviously, there's similar needs and even increased needs in a time of war like this. But most of what we're doing there is we go and we work with the local surgeons. And the surgery training programs there are a little bit different. They don't have people who are as subspecialized as we do here. And so we're teaching more generalists. So this could be, pediatric orthopedic surgeons who have to deal with the hand stuff. Sometimes there's some pediatric plastic surgeons. They don't typically do as much hand work there as we do here. And then sometimes even just pediatric general surgeons and so on that we go and we team up and we do go back to the same. We have a network right now of 3 hospitals that we go to consistently that are dedicated to children. And so we have a whole group of surgeons there that you become really close friends with. And while we're there, what we do is we see a lot of patients together and then we select which ones are the best candidates for surgery. And then we operate on all those patients together with these local surgeons. And then we're only there typically for 2 weeks and then we come home. But the great thing is we have a nice ability to communicate with each other through WhatsApp, which is, a text communication app that's much more global and international than many of the others here. So we're constantly getting pictures of our patients. We're getting questions. They have a great understanding of many of the things we do, but there's some things that they're still learning. And so we are constantly communicating back and forth. And then what they're doing while we're not there, now they know what our expertise is. They're starting to collect patients and get them ready for our next trip there. So what's been really cool is we go there and we teach all these new techniques, and selective neurectomy is one of them. And it's really fun to go back, and then they say, hey, we actually did those surgeries now while you were away on these patients. And so we'll follow up with those patients as well. And we get to see them applying what they learn while we're there, which is quite amazing. But there's a surgeon in Lviv, which is one of the larger cities in Western Ukraine that we go to, that is mid-career, and she's done a lot of this pediatric upper extremity surgery for many years, and she treats a lot of kids with cerebral palsy. And so we went through how this selective neurectomy procedure works, and she recently sent out a sort of invitation to patients in her area to come and be screened. And so she's actually collecting a bunch of patients for us now and getting ready for our next trip to go back. And the really cool part of it is we have a pediatric hand study group here in the United States, which is, our group of basically American pediatric hand surgeons. And we have an international visiting fellow that's a guest that is invited to our national meeting every year. And they get some funding to come and spend some time, obviously, at the conference, but then they also get to spend some time with us in our hospital system for a couple weeks. And this surgeon who I work with in Ukraine was just selected to be our international traveling fellow this coming year, which will be a lot of fun. And so we're kind of working on planning that right now. And then she's going to come here to Utah to join me in my practice for a couple weeks and just see how our system works here. So it's been a great collaboration. I've certainly learned a lot from them as well. I mean, I learned some techniques while I was there that I just applied, in fact, this past week, and what I do here. And so it's really a give and take, and been a great new avenue of my practice.
Well, as the old Ed line goes, it's the gift that keeps on giving, isn't it? Both in terms of being able to share care, being able to share education, and change your perspectives and horizons.
Yeah, that's totally right. And that's our goal. We want to build capacity there. I mean, we love going, and we're surgeons, so we love operating. But the more important part of that is teaching the local surgeons so they can carry this on. And it really offers them something they don't get. They, especially now in this time of war, they can't travel around like they used to get more subspecialty knowledge. Most of the surgeons are fairly confined to the country, particularly the males. You can't even leave the country without very special approval if you're between the age of 18 and 60. It's a really good opportunity for us to go to them and give them, some of the knowledge that we have and help broaden what they can do and so on.
Well, and what a great thing, as the people you train there get more facility, then they will train people. And it's just amazing.
Yeah, one of our groups is actually even setting up a formal training program there. So anyway, it should be interesting because they really don't have the training of what we get in plastic surgery here. So for example, the orthopedic surgeons have to be the burn surgeons, because
Wow.
they don't really have an avenue for training plastic surgeons there. And so other people just have to pick it up and do it. And anyway, so there's a training program that's in the works that will be sort of orthoplastics, and this concept of combining some of the principles of orthopedics with the principles of plastic surgery, which are plastic surgery is a little bit more focused on rebuilding the soft tissues, and that's a big gap in their training there.
Well, Shawn, thanks so much for your time. Thanks for what you do, and thanks for sharing your expertise. We'll look forward to talking to you again in the future, but in the meantime, safe travels.
Thank you so much, Paul. It's been really fun being on your podcast now a couple times, and I really appreciate what you do to get the knowledge of these subspecialties out there.
Well, we'll look forward to having you back.
Thank you. Take care.
All right. And to our listeners, keep listening and tell your friends. We'll talk to you next week.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, The content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.